Hi, good evening, everybody. We're just going to, as usual, have a slightly slow start just for a few minutes while we just people join. This is the last lecture in the what we call the Red Lectures, Research, Education, Development. We will be stopping after this evening, and we will put a new program together for the autumn of 25. Just while everybody joins, I was also going to, for those of you who are clinicians and collect CPD for your appraisals and so forth, something that I meant to do and haven't got around to, but we will find a mechanism to get people CPD certificates for an hour of CPD for each of the lectures. And I think that will help our clinical colleagues in particular. I understand that people who join, some of whom are patients, some of whom are laboratory scientists and what have you, people from a variety of backgrounds. But for those of you who are clinicians, that might help. So what we've got as the last lecture of the 2024 series is the topic of radiotherapy. I'm very pleased to introduce my colleague, Dr. Rachel Brooker. Rachel has been a consultant for 2 or 3 years now in Liverpool. I did a higher training in Liverpool in clinical oncology. She did a PhD with our research group and did a PhD in and around the topic of radiotherapy and chemotherapy, and developed a taste for clinical research, which we've propagated and encouraged Rachel. And though she's a slightly reluctant speaker, but for no reason at all. And Rachel actually has been delivering some very nice clinical research, and it's just a pleasure to introduce Rachel this evening. I had wondered about following on with some content on osteoradionecrosis, and when I put the series together with colleagues earlier in the year, it seemed like a good idea. As this week went past and I wrote the slides, I actually realized it was not a good idea in a number of ways, just because it overlaps with radiotherapy. And I've made a decision, if everybody's happy with that, to keep my powder dry, and I will present this lecture as part of next year's series, because I think it's better to allow Rachel Brooker to speak with a whole session rather than half a session and trying to chase her off the podium, as it were. So with that, I will stop sharing the screen and hand over to Rachel. Thank you very much, Rachel.
Thanks so much, Richard. I'm just going to share my screen, and hopefully this is all going to work well, it says. So I hope everyone can see that. Just shout if you can't.
Yeah, we can see it.
Okay, great. So yeah, I'm Rachel. I'm one of the head and neck oncologists at Clatterbridge Cancer Centre and working within the Liverpool Head and Neck Centre. I've got a specialist interest in giving radiotherapy and chemotherapy to patients with head and neck cancer. It's a real pleasure to be able to talk to everyone tonight and be part of the Red Lectures, which I've managed to listen to a few of them over the past few months, and they've really been brilliant. So it's great to be part of the series this year. And I was asked to go through a radiotherapy update, and I hope to achieve this in part because it's a really vast topic, and it's probably impossible to talk through everything in its entirety on one Tuesday night. So I thought I'd give a brief overview of the current state of play in our practices, what things are like when you consider treatment in the real world, really, and some of the novel treatment approaches on the horizon in radiotherapy that will be applicable in our specific patient cohort. So let's get started. So we've got quite a big and busy centre in Liverpool, and within a team of 3 other clinical oncologists treating head and neck cancers, and we give upwards of 350-ish curative treatments per year. Lots of our patients have really high levels of frailty and coexisting medical issues, which can sometimes limit the options we have. And about a third of patients will be referred to us from the outset with incurable disease. And despite those curative treatments that we give that I've mentioned, approximately half of those patients will recur after definitive treatment as well. So not a great outlook for our patients, really. We give 200 palliative radiotherapy treatments and the same number roundabout of systemic treatment courses as well. So these treatments are extremely aggressive, especially in the radical setting. Most patients will experience a drop in their quality of life following radical radiotherapy or radical chemoradiotherapy for their head and neck cancer. And you can understand why when you're faced with a patient who has head and neck cancer so advanced as the pictures that you can see that I've displayed of someone's CT scan with such advanced nodal disease and also such a big primary disease as well. These deteriorations in quality of life can last in the long term and have a really massive impact on patients' physical and psychological well-being. And around 80%, which is a huge number, express at least some level of decision regret following treatment. And 30% of our patients don't end up returning to work after their treatment as well. So I hope these pictures give an indication of where we've come with our radiotherapy treatments over the last 50-ish years. This machine on the left was one we used in the 60s with a couch that moved just in a single plane with minimal immobilization and no onboard imaging. And now I hope you can appreciate on the right how things have come on with our fancy new machines we have at Clatterbridge with couches that can move in 6 degrees of freedom. We've got onboard cone beam CT imaging. We have fantastic immobilization methods, which means we can achieve some amazingly precise radiotherapy plans, which in some scenarios can give proton treatments a run for their money, especially in terms of our motion management as well. So I always kind of put this slide when I do a presentation just to take me and as well as everyone else back to basics of what we're trying to achieve with our radiotherapy. Head and neck radio. Oh, sorry, that's my dog. Hang on a sec. Icky. Sorry, apologies, everyone. Yeah, so radiotherapy can be really complex, and we treat an area with very high concentrations of organs at risk nearby. And we're always trying to tread a fine line between cure or maximum control and keeping the nearby tissues safe. And this is shown in this graph really, where the red line is our tumor cell kill. So what we're trying to achieve is killing the tumor with these high doses that are required to do so. And the purple line is the percentage probability of complications to the normal structures nearby. We want to really try and keep this therapeutic window as wide as possible, but unfortunately in head and neck cancers, often we see that the therapeutic window is quite narrow because we are having to use quite high doses. This again, in this slide shows how things have come on in leaps and bounds. As such, we're seeing reduced toxicity and more robust radiotherapy planning. So on the left, you can see a more traditional and old-fashioned radiotherapy plan where we used fields to treat tumours. We had a radiotherapy beam coming in from one side and the other side, and aiming to treat the red area in the centre, which is our target area. And although this plan is quite good, you can see there's a nice red area across the whole target. We are treating brainstem and temporal lobes when they don't need to be treated and increasing patients' toxicity. So the picture in the middle is our newer techniques, our intensity modulated radiotherapy, where we can really sculpt and move the beam and modulate the dose that's being delivered. We're able to come off brainstem, come off temporal lobes, and really still give the dose that we want to the central target, minimizing the toxicities to patients. And then again, the picture to the right is some of our more modern organ at risk sparing, where we're trying to spare more and more tissues nearby the target. You can see on this laryngeal plan where we've aimed to try and spare the carotids, and the dose is really bowing in to try and reduce the dose to those organs as much as possible, potentially reducing the chance of long-term strokes for patients in the future. So we do have such amazing technology, and we're pushing boundaries with our machine capabilities all of the time. But despite this, we're still having problems delivering that treatment. and the real life complexities of treating patients in our region and in some other regions as well are vast. So we're going to talk a little bit about that now. So this is really quite an old piece of work that I did with Professor Shaki and Dr. Sacco when I was doing my PhD. But I still think it sends a really important message. It was an audit I did looking at the impact of head and neck cancer treatment as patients moved through their treatment course. And we looked at a cohort of patients having major head and neck resections and their subsequent adjuvant treatment. So we measured their fitness for treatment before they had the surgery, which is the blue bars on this graph. And again, before they went for their radiotherapy, which is the red bars. So you can see that there's a drop in performance status for patients even before they went for the radiotherapy, and that was even in the fittest patients. And out of close to 100 patients we looked at, those who should have received concurrent chemoradiotherapy, only 20 patients actually were signed up for the full course. And of those 20, only 9 patients actually completed all the cycles of chemotherapy they were planned for. So how can we start to address these challenges? Well, it's really, really difficult. We know we don't only have problems with frailty, and that tolerability of treatment is a problem for even the fittest of our patients. But this is coupled with the recently published data on incidence rates, which means we really do have quite a huge problem in the region. So I realised this map has been shown a few times during the lecture series, but so important to really take in and discuss the increase in head and neck cancer incidence and mortality. And within Merseyside, we know that we have rates almost 30% higher than the national average. And we know as well that patients are twice as likely to be diagnosed with head and neck cancer in areas of deprivation compared to more affluent areas. Within Merseyside, we have some of the most deprived areas in the UK, and patients often present really late. And as a consequence of that, mortality is higher. And these documents have published some generic guidance on to how to address these issues: reducing tobacco, improving early detection. And these are really important solutions to these problems. But I really think we need to focus on the areas of the UK that we're looking at with these initiatives and the regional differences and complexities within them before we attempt to improve them. So this is a diagram representing the measures of deprivation across the city. I think it really nicely shows how deprivation can affect life expectancy. It's been produced by Liverpool City Council. And it just depicts the different areas of deprivation across the city, the more deprived areas being the red station stops, and those in green, the least deprived. And you can see just how travelling a few stops on a train line from Aigburth to Bootle, there's a significant change and drop in life expectancy for individuals living there by almost 15 years. So as I mentioned, it's really important not only to understand the disease we're talking about, but also the people and the communities at a deeper level. So rates of head and neck cancer are high in other areas of the UK, but how does originating from Merseyside affect the risk of certain conditions? So I've put a photo up of wheelie bins because I recently moved out of the region, having lived in Liverpool all my life. And when I told my friends and family, they weren't really concerned about the move itself, but were absolutely devastated that I'd be giving up my purple bin. So this sounds crazy, that why they would be bothered about me giving up my bin. But a purple bin has become some kind of symbol of scouseness in the city. And they were so upset that I'd be saying goodbye to mine. And them talking about it even made me start to miss my purple bin, which is ridiculous. But what has that got to do with head and neck cancer? Pretty much everything, I think, because it means, and it really indicates the strong identity that we have in the city. And these identities shape our views and values, shape our interactions with families, friends, and our social behaviours. The social influence in Merseyside and other northern cities can be really strong. And it's a driver to our rituals and behaviours, such as drinking alcohol, for example, that can increase the risk of head and neck cancer and other cancers. So these are social norms, but they're really deeply ingrained and even encouraged in the region. So it's very difficult to frame a behaviour change in a way that might be sustained. So these small eccentricities about different regions will vary across the board and within the country. But any attempts to narrow disparities will really require knowledge of what makes certain areas tick to be successful. An example of this is our rates of alcohol-related deaths in the region. I think it's fair to say you can almost overlay the two maps and you'd see pretty much the same colours becoming darker as you go towards the northern areas. Unfortunately, our rates of alcohol-related problems are increasing, and there's a very sharp rise of the graph once you get to the COVID era and the COVID years. And this is linked to people living, being isolated and having more mental health issues as well. So from looking through these data, there's almost a perfect storm in the region with the issues we've mentioned. And they're paired also with changes in the way that we live across the UK. So we're waiting longer to have relationships, waiting longer in choosing not to have as many children, changing priorities and our life choices. And that means that more people are living alone. And from this, they have less access to social networks, less informal care from family and friends, and inequalities start to increase, gaps in wealth and health widen. So although I'm sure I'm scratching the surface with going over some of these statistics and issues, I hope it does kind of show how complex and ingrained these are, and that narrowing these inequalities is going to be really challenging. So I thought I'd just talk through a case which I have come past my team very recently, which I admit is on the more extreme side of the scale, but is unfortunately more common than I'd like. So this was a gentleman who was referred to me, and he was a male in his mid-50s. He had a locally advanced left tonsil cancer, which was HPV positive, but he was also a current smoker. So he underwent his robotic resection with the ENT team, and sadly, once I got his with a heavy nodal burden in his neck, 2 nasty-looking lymph nodes, and this perinodal vascular neoplastic emboli, which is basically a red flag for aggressive disease. So I was referred from their team so that I can give him a bit of radiotherapy, which is a common phrase that I see in letters sent to me. And when I saw him, it became evident that he was going to struggle with his treatment. He lived alone. He didn't have any support at home. And again, another red flag to me is a very short consultation time. It's clear he had quite poor health literacy and he didn't truly understand the gravity of the situation. He also admitted to drinking alcohol earlier that morning. And for a few, taking all this into consideration, despite his very high-risk features, we agreed to just press on with radiotherapy alone. And I didn't sign him up for the concurrent chemotherapy that he should have got as standard of care, mainly because I was concerned he wouldn't complete treatment. So after his first week of treatment, I got this email basically telling me that he was struggling at home with his social circumstances. He was struggling financially. He was spending a lot of his money on his alcohol. And he didn't have any friends or family and relied on his local shop owner to keep hold of his money so he didn't spend it all at once. I was told he was going to need a lot of support moving through treatment. So I was interested to know what a lot of support going through treatment meant. So I went through his notes at the end of his treatment, and I saw how many healthcare workers, which is the column on the left, had been involved in his care, and it was massive. Not only that, he had 2 admissions, both of which he self-discharged from after 24 hours. And the reason for those admissions were purely for social support. He had 2 incident forms. He had 3 police calls to try and encourage him to come to treatment. He had 2 missing person reports. I had 60 emails over 20 working days about him and concerns from the team over his compliance. And I'm sure many other members of the team got additional emails as well. I was unable to quantify the number of workforce hours used to try and support him through treatment. And despite everyone's, gargantuan effort to get this gentleman through treatment, he still absconded after fraction 20 with 10 treatments left to go. Unfortunately, I'm still not able to get in contact with him, but we have done another police call and another social work call to his house, and he is safe and doing okay, I'm told. So sadly, this is not an unusual scenario, and this is kind of demonstrated by a piece of work I did with the social disparities group that we've got running in Liverpool. And this piece of work looked at a patient cohort over a year, and we looked at why patients weren't turning up for their treatment. And not surprisingly, the majority of our patients lived within an area of deprivation, which is the score of 1 in this chart on the left-hand side. And this was correlated with missing treatments. Also, the majority of patients, well, half of our patients relied on hospital transport to get them to and from their treatment, and that again was correlated with a missed fraction. In terms of radiotherapy reviews, usually patients would get that once a week, but we're finding that about 70% of our patients were needing additional ad hoc reviews during their treatment on top of the standard of care, which posed a substantial financial burden on the healthcare team. So we're moving all of the time to personalization based on different biomarkers and tumor biologies, but also we need to improve our personalization based on what's achievable in the real world for individuals. And I think seeing radiotherapy as a drug which can be adapted and used in different ways to improve patient outcomes is really important. So we need to find the holy grail of the optimal in between for patients. So this is a quote from Norman Coleman, who was a radiation oncologist and government advisor in the US. His main driver was to address disparities in access to cancer care. And he believed really in helping underprivileged people in accessing the care that they need. And his ethos was really to make radiation, in inverted commas, druggable. So it's a different drug, a different dose and schedules. Sadly, Dr. Coleman's died this year, so hopefully through this talk I can tell you about some of the work he was an advocate for. So this is an example of making radiotherapy druggable and having realistic goals for treatment. So it's yet to be published as a full article, but this is the HYPNO trial. This recruited patients across low to middle income countries and was aimed at saving resources and providing patients with as optimal treatment as can be managed. Patients were randomized to 33 treatments or 20 treatments. Interestingly, it was having 20 treatments were found to be non-inferior, with importantly more patients finishing treatment in the 4 weeks of radiotherapy compared to the 6.5 week treatments. So you could argue the patient I presented earlier, would he have benefited from this approach, completed his treatment, and limited the impact on the medical team as a whole? So it's difficult to implement this given the different populations that were examined, but still I've started to consider using this regime as an option for patients who are frailer and who I feel are at risk of poor compliance. So we can't go through a talk on head and neck cancer without talking about de-escalation in the HPV era. And this work by Nancy Lee in America, I think is going to be a game changer for our patients. Her team is de-escalating patients' treatment based on hypoxia status of their tumors, assessed with these special PET scans as an imaging biomarker. So with the aim of achieving significant toxicity reduction without compromising on survival. This is a phase 3 study, which is ongoing, and I think they've treated over 500 patients now. So what the aim is to reduce the dose of treatment and give it over 15 fractions instead of the normal 30 fractions, with only 2 cycles of chemotherapy instead of 3. And that is risk adapted for patients demonstrating a negative hypoxia PET after 2 weeks of treatment. So this is going to prove very popular, as any reduction in fraction numbers and toxicity will encourage compliance for those patients struggling with attendance and complex social issues. So we talked about modifying radiotherapy treatment in the curative setting. What about trying to come up with potential manageable modifications for our palliative treatments to try and improve patients' quality of life and optimize survival outcomes? So at the moment, our palliative radiotherapy is really quite good and is a favourite among us clin-oncs in being able to gain control of local disease quickly. It's a manageable option for most. And this is a survival curve from some audits we've done this year on some of our palliative treatment courses. You can see that the higher the dose, the better control. And we're getting around a median survival of about 12 months for patients having the higher dose treatment. And this is the rationale behind some of the work Dr. Haradas, who's one of my fantastic colleagues, has been doing, who's been looking at delivering a radiotherapy technique called SBRT, which is a palliative treatment, but a treatment that is given over a short period of time with high doses per fraction, trying to deliver a ablative dose safely with very tight treatment areas in order to gain as much local control as possible. We weren't actually sure whether this treatment would be achievable and whether we'd be able to safely treat patients with organs at risk of such importance nearby. But Dr. Haradas and the physics team at Clatterbridge have worked really hard in coming up with a solution to that, and they think they do have a treatment technique now that's going to be moved forward into a phase 2 study if possible. And can we use SABR in other settings as well, pushing the dose up to make it to optimize control? And this is a phase 2 randomized study with patients with metastatic head and neck cancer, with importantly a controlled primary disease and only small volume 1 to 3 metastatic lesions. And this study really selected out a very good prognostic group with a median overall survival of over 40 months, which is sometimes unheard of in our patient group. But those with just single sites of metastatic disease, it's something that we can really start to consider. These patients were randomized either to SABR by itself or SABR with chemotherapy. And interestingly, they found that the SABR toxicity alone was only around 9%, which just shows how it can prevent that significant deterioration in quality of life that we all fear. It also means that potentially you can delay time or extend the time before patients need chemotherapy and immunotherapy, and really, as I said, maintain patients' quality of life. So when the patients do get to the point of needing chemotherapy and immunotherapy, then we're still limited as to what we can offer for them. Treatments in the advanced setting still have only, well, they have improved in recent years, but still only have a significant benefit in the minority of patients. This is demonstrated in this survival curve from Keynote 048, and this compared patients' treatment with combination chemotherapy, which is the red line, compared with checkpoint inhibitor pembrolizumab, which is the green line survival curves. So the blue curve shows that patients do benefit from immunotherapy, however, not to the same degree as other solid tumours. And there's much interest in trying to improve responses to checkpoint inhibition to try and improve outcomes for patients with head and neck cancer. But it's important always to keep in our minds the frailties and difficulties we've already spoken about at length earlier in the presentation, and recognise that realistically, escalating therapies with multiple treatment combinations is often not an option for our population. So I know that the future looks bright for patients who are fit with metastatic head and neck cancer, and they're well enough to escalate therapies. But as mentioned, for others without and within those head and neck cancer patient cohorts, we need options that can maintain quality and can manage the sometimes urgent symptoms, and particularly gain control of local regional disease, which so often is the driver of patients' symptom burden, quality of life, and prognosis. So could the answers that be in front of us, and using radiotherapy in a different way? And I'd argue that radiotherapy needs to be within this list of adjuncts to immunotherapy to try and improve how it's working. So when I was trying and often failing to understand radiobiology, the textbooks often talked about the 5 R's of radiobiology. And it's really important in describing how individual tumors and normal cells respond to fractionated radiotherapy, and the differential effects of dose fractionation on normal tissues versus tumor responses. So within these circles, you can see all the different R's that we get taught about. So repair or recovery of normal and tumor cells from sublethal radiation damage, reoxygenation and redistribution of cell cycle of tumor cells in between dose fractionations, and repopulation, which is so important in particular SCC, which describes the increase in cell division of normal and cancer cells after radiation in response to the decreasing numbers of cells, along with the intrinsic radiosensitivity of normal and tumor tissue. But now we've got 2 extra R's for the trainees to learn about, which describe radiotherapy's ability to reactivate the immune system and reverse the immunosuppressive ecosystem around tumors. So one interesting area of radiation and a novel area that everyone has been talking about for a number of years now is the elusive abscopal responses. And they're often talked about in radiation oncology, where radiotherapy can change tumors into these an in situ vaccine and stimulate the priming of T cells, resulting in regression of non-irradiated lesions. So this is a paper I read when I was doing my PhD, and I still find it amazing that you can induce a response in an unirradiated area by treating a lesion in a different area. So preclinical models have time and again told us that this is a possible consequence of treatment, but in practice and in humans, these responses can be really rare. And this paper just showed and is a good example of using radiotherapy as a drug at different doses. You can see that giving these high doses, but 3 of them to one tumor area, caused a response in the mouse to the left on with the tumor in the flank there. Giving a very high dose, just a single shot on the right-hand side, although treated, the primary tumor didn't affect the other tumor on the right flank of the mouse, and different doses had a different cellular effect. So this is an example of a patient in my practice who I treated with metastatic head and neck cancer. She had multiple lung lesions, and I think you can see just one there in the picture, and a very advanced laryngeal cancer. She wants to have immunotherapy at the outset, so we went ahead with treatment for her. But after about 5 cycles of treatment, it became very obvious that things weren't working very well. Her breathing was laboured and her swallowing is not as good. I'm sure a lot of the ENT consultants on the line will be looking at this scan very concerned about her airway as well. And with her immunotherapy. So I quickly brought her in for some palliative radiotherapy with some steroids to make sure her airway was safe. And remarkably, there was a fantastic response. She had complete response with metastases in her lungs. And this is her larynx 2.5 years later, with the tumour completely dealt with just palliative radiotherapy. So you could argue I might have just bought her some time with her palliative radiotherapy, but nevertheless, her radiotherapy treatment did turn the tide for her. So initially everyone, as I've said, was really excited about the potential of abscopal responses. We have a treatment with minimal side effects and toxicities potentially going to improve immunotherapy responses. However, McBride and his team have confirmed that the responses in head and neck cancer are few and far between, and that the volume of irradiated lesions, numbers of them, and the fractionation you use is really important. So this group gave stereotactic radiotherapy to one site of metastases when being treated with immunotherapy as well, and compared to that to patients just having immunotherapy alone. The response rates were the same in both arms, and importantly, this study confirmed that giving the two treatments together was safe, and the toxicity profile was similar. Interestingly, in an unplanned analysis, the proportion of patients responding with virus-negative disease was higher than with nivolumab plus SABR than with immunotherapy alone, and it posed the question of whether radiotherapy could be used to turn cold tumours into very immunogenic tumours and encourage the immune system to start attacking them. So coming back to this curve I showed at the beginning, when we're talking about making radiotherapy seem more as a drug, then can we take a minute to think about what might happen to tumours at lower doses? Thinking about it not causing this tumour cell kill, but actually thinking about changing and modulating the tumour environment to try and flip it into one that might respond to immunotherapy. So this is the thinking behind the principle of low-dose radiotherapy, where we barely eradicate a tumour, but use it as an immunomodulatory agent that triggers a distinct anti-tumour immune response and changes the tumour stroma, essentially opening the doors to an influx of immune cells, which may be particularly useful in squamous cell carcinoma, where the doors are often closed. So just a few mechanisms for this include increased cytokine secretion, antigen uptake, change in the adhesion molecules, and changing the macrophage polarization. This approach has been attempted in clinical studies examining patients with non-small cell cancer and melanoma. And this is a study by Patel in 2021, reported on about 74 patients with non-small cell lung cancer and melanoma that were progressing on immunotherapy. They also received high-dose radiotherapy, mainly SABR to one lesion, but also had low-dose radiotherapy to other lesions. Importantly, not every lesion was treated. So you can see in the picture to the right, the reduction in avidity on this patient's PET scan with the use of low-dose radiotherapy, and the change in immune cell infiltrate when they examined pre- and post-treatment biopsies from the same site. So the low-dose radiotherapy was given to this patient's left neck, and after they just had half a gray twice a day, they had a really good response on the left neck, and the biopsy samples have shown a change and an increase in the immune cell infiltrates from the left pictures to the right. This also demonstrated an improvement in lesion-specific response rates for those receiving low-dose radiotherapy, which was 53%, compared to the non-irradiated lesions. And this is just showing this with the blue bars showing the partial responses in individually low-dose treated lesions compared to those not irradiated in the pink. So while radiotherapy releases tumor-associated antigens to trigger immune activation, it can also lead to immune suppression by increasing the production and recruitment of regulatory T cells and immunosuppressive macrophages. So that's potentially why it doesn't work for everybody. There's the potential effect of the volume of irradiated tissue in the past, the location of that previous radiation, and other factors such as the microbiome and the environment, if a patient's a smoker, for example. So it remains a really attractive prospect indeed that we might be able to use a variety of doses and sites of irradiation in some patients to provide them with improved responses. And this is particularly relevant in our patient group as it provides a safe and cheap option with very low toxicity burden. And importantly, all of these interventions mean that patients have more choices. It's so important for patients to have choices when they're considering their cancer therapies, so that they can make some shared decisions and prevent that treatment-related regret that I mentioned at the beginning of the talk. So yeah, I think that's it really. So I'm finished now. I'm happy to take any questions that anyone might have. Thanks very much.
Thanks very much, Rachel. That was really thought-provoking, and you covered a lot of bases there, and I'm very pleased I didn't try and follow that with a few slides I'd put together. So I've got 2 questions, and then other people will come up with questions. So one of my questions was just tapping into your Scousness and your thoughts about what the culture is of Liverpool and how it might help or doesn't help, and it might intersect with your professional life. Common preconceptions that patients walk through the door with when you start to talk to them about radiotherapy. What's your experience of it? Is there a difference that is documented in the thoughts that are out there about radiotherapy and what it involves and who shouldn't and shouldn't have it and all the downsides and upsides, compared to, say, a Liverpool population to other populations? Has anybody ever looked at that?
Not that I'm aware of. I still think even amongst clinicians, as radiotherapy seems like a dark art, like nobody really understands or knows what happens behind the doors of Clatterbridge. I don't know if you'd agree with me on that. I feel like even amongst clinicians, there's a lot of opinions on what it used to be like and what it's like now, and some people feel it's just, putting your head into a nuclear reactor. I think Professor Shaki sometimes says, and it's all these comments that sometimes can change perspectives and change views on what you're trying to achieve for patients. And I think it is become more of an art than just giving people 60 gray and blasting their head and neck. It's not like that anymore. And I think it's appreciating how much our technology's moved on and what we can achieve. And I think that's probably why we're treating patients more and more. We're attempting to treat these huge tumors that we would never have even dreamed of before, because we can. And we're able to pull off the spinal cord, we're able to pull off the base of skull and things like that, which we couldn't do before. So as a consequence, we need to really level the playing field and understand how we consent patients and what their expectations are, because we're embarking on very aggressive treatments to big areas. Yes, we can do it, but should we be doing it? And is it actually changing people's outcomes? I'm not so sure.
Thanks, Richard. My second question was, coming back to your data about missed fractions and just the clinical importance of that, and about completeness of treatment, and how important is it when you set a course of radiotherapy that you complete it? How important are missed fractions or finishing radiotherapy earlier than planned in terms of the therapeutic benefit? Is there clear evidence on that?
Yeah, I mean, it's hugely important. Yeah, it's
Yeah.
absolutely important. In squamous cell carcinoma, it's classed as something called a category A tumor, where you often see huge amounts of repopulation, so cells growing as a consequence of missing a single fraction. So unless patients complete that whole course, say of 6 weeks, once you set them off on that road, their outcomes are massively affected by completing a course early, which is why I'm like an advocate for trying to be realistic about what we're trying to achieve, and maybe giving 4 weeks of treatment instead of 6, because we do all of our radiobiology calculations. The dose per fraction is different, so by giving it in 4 weeks, it sounds like you're giving less of a dose. You're not. The radiobiology of that is close to an equivalent to a 6-week course. And it just means that patients' expectations are leveled with yours, and they're more likely to complete. But yeah, in answer to your question, missing a fraction is huge. We would have to double up on the treatment. in a day of their course, so they'd have to come twice a day instead, or treat on the weekend, something like that, to try and reduce the treatment spanning over a longer period.
In that context, how did it ever get into practice that we don't give radiotherapy at the weekend? And how can it be safe?
It's resource. We don't, when you consider that just in head and neck practices, we treat, 400 patients a year.
Yes.
And with that, you've got all of our breast patients we treat, prostate cancer patients we treat. We basically touch every cancer tumor site. And within the NHS, we just don't have the resource to open machines on the weekend. And the staffing.
I've never asked the question, but in very well resourced centres, let's just say in private health centres in the States, where they really do have limitless money when it comes to these things, do they irradiate through the weekend?
They do 6 fractions a week, some centres, yeah, or they do hyperfractionation, so can treat twice a day in some affluent country. Well, I mean, I suppose we're an affluent country, but our resources are constrained, really, when you look at how many patients we treat.
Yes. Well, we're busy as doctors in the UK, and I think that's true across the board. And it's true in our A&E departments. It's true of many of the departments. We do get through quite a lot. And I think it is also worth remembering where we are. So I'm reflecting some experience in the States, and I remember making some observations about the head and neck radiotherapy practice in Memorial Sloan Kettering and MD Anderson, where they had a lot of resource compared to us. And they would do anything to avoid misfractions. They would do anything to avoid treatment breaks. They would go to quite extreme levels to support a patient to get them to have that day's radiotherapy. It was considered absolutely critical. Whereas, as your data shows, we sometimes fail for a variety of reasons, many of which are considered unavoidable, but essentially it's the amount of resource we've got. And when you support a patient, what actually does change for that patient, or potentially not enough. But I'm also reminded of colleagues who work in developing countries where they don't even try to give radiotherapy to most patients because there is no resource. It just isn't realistic. You can actually get people through surgery, you can get people to have drug treatment, but the idea of supporting a patient in a regional centre to give radiotherapy over a 6-week period is just not on the cards. And of course, we are in the middle. Whilst we're not at the very able to support people and support treatments like the very top US units, or maybe even the top European units, we have this overall guarantee that we will catch people from the poorest backgrounds and from the most distant regions of our country and give them, in theory, the same treatment as we'd give everybody else. And of course, that isn't that common around the world, is it?
No, definitely not. Yeah.
Sorry, I'm hogging the questions. And can I invite other questions for Rachel? Everybody's gone quiet. Everybody stayed. We had 20 at the end, 19 at the beginning and 20 at the end. You grew your audience. Well, Rachel, it is 10 to 8. I'm going to thank you very much for closing our Red Lectures for 2024. I was reflecting back, we've had some very varied lectures, and most of them were homegrown. We only had Vin Polari from outside the group, really, from the Marsden academic group that were able to do that. Thank you very much. And all the comments are coming. Thank you, Rachel. You've really given us food for thought. You will be invited back again. And I just want to wish everybody, obviously, good evening and Merry Christmas. And we'll see you in the new year. Thanks, Rachel.
Christmas, everyone. Thanks so much.